Another session, CRRT prescription, tailoring therapy for individual patients by Dr. Rajshekar Chakravarthi, Senior Consultant Nephrologist, Yashoda Hospital, High Tech City, Hyderabad. I would like to request moderator on the stage, Dr. Girish Narayan sir, Senior Consultant Nephrologist, Yashoda Hospitals, Dr. Manisha Sahai Madam, Professor of Nephrology, Osmania Medical College, and Dr. Raja Karthik sir, Additional Professor Nephrology, Nizam Institute of Medical Science.
Very good morning all, and thank you for inviting us here. And it's a pleasure to introduce Dr. Rajshekar Chakravarthi. He doesn't need any introduction, but still, he is Consultant Nephrologist, Clinical Director and HOD Nephrology and Transplant Services. He won the Best Paper Award in PDSI August 1998 Hyderabad, Travel Grant, multiple travel grants. He has received
Manisha,
so far.
I didn't give all
And
that.
Tanker Award for the best paper presented at ISN conference December Delhi. Fine, it's there for me to read.
20 years
So
back.
So you should have updated it. So there is much more to Dr. Rajshekar Chakravarthi than meets the eye. We all know him. I mean, we have heard him speak on multiple platforms, national as well as international. He's also a working group member of KDIGO. So, and we always see him in the CRRT conference, probably Ravindra Mehta of India maybe. So over to you, Dr. Rajshekar Chakravarthi.
Yeah. Friends, it's my pleasure to discuss this relevant topic. Most of you by now know Manisha is a very, very generous lady. So if you don't know, you will come to know in future. So whatever Dr. Shakthirajan has put as basics, my job would be just to give you some concepts about prescribing CRRT. This is one of my favorite slides. Dr. Emil Paganini, I don't know how many of you have know him or remember him. He was a very prolific publisher on AKI, and this was from Seminars in Dialysis in 1996. He had talked about initiating intermittent hemodialysis, and then the learning curve that we had. At that point, some of us, even in the 80s, had done CAVH. I'm not sure how many in the audience would have. Inside the OT, bedside, we used to puncture the femoral artery, connect it to a hemodialysis circuit with a polysulfone cartridge, and we got patients out of acute situations. Anyhow, depending on what you need for your patient, cytokine control, in a heart failure, fluid control or uremic control, you may want to choose a particular type of modality, and each one of them, to elaborate on what Dr. Anuradha started as the discussion. You have 10 patients in your ICU. Some of them do well on intermittent hemodialysis. Some of them will do well on HDF. A very few of them may not tolerate these procedures, and you may want to choose a continuous renal replacement therapy. So a good unit should be able to offer different modalities depending on the patient's hemodynamics and what the requirements for the patient in the next couple of days. It comes down to when do you want to start it, depending on the indications, what is the most appropriate therapy. So the present concept is the patient has a capacity which is finite. It is not an infinite capacity. You know, in the next 24 hours, you need so much of fluid to go in for nutrition or transfusion or antibiotics, whereas the demand on that patient may be more than what the finite capacity of the kidney is. Keeping this paradigm of demand capacity in the patient, you may want to choose a particular modality. And then equally important, when do you liberate them from this particular support that you have started? This is a paper that we wrote 2 years ago, Nata Chai and myself. The exact reason this paper was asked from us was the developing world CRRT is not an easy thing. For most of us, Shakthirajan did mention, even in MMC, if they are able to do it, there are challenges, and we could classify them into challenges or barriers for CRRT: environmental, exposure, socio-economic, and process of care. For you and me, even if you are working in the best of the units in the country, so-called tertiary or quaternary care, you still have these challenges in our country. Cost is not easy. You first need consent from the primary team if the patient is not under the intensive care or nephrologist. Then you need consent from family, you need consent from the billing, and there are so many consents that you have to take. By the time that you decide to do it, you may have lost the or missed the bus. So let me start with a young male, 38-year-old farmer by occupation, had progressive swelling over 4 months, presented to a hospital in Vijayawada with abdominal pain and shortness of breath. He had diabetes 2 years ago but was not on any medication. Creatinine at the time of admission in Vijayawada was 1.7. They found that he had severe metabolic acidosis. They considered pancreatitis because of the pain abdomen and the renal failure. He developed hypoxia. They suspected embolism, but they could not do a CT. Shifted the patient to Hyderabad. When he presented to our emergency, blood pressures were 80/40, heart rate 120, gross fluid overload state. So he had acute kidney injury, and the creatinine by the time he came to us was 4.2. So this was a rapidly progressing renal failure. And what was most striking was the amount of acidosis that he had, and this patient was taken up after talking to the family on HDF, what Dr. Anuradha asked us, hemodiafiltration. On HDF, he deteriorated, and we had to switch over because the working diagnosis was a cardiogenic shock. The echo showed a very high pulmonary artery pressure and right heart failure. So he received all the regular treatment, and because HDF he did not tolerate, we switched over to CRRT. So I am supposed to spend some time on this prescription. So the things that you would want to look at as subheadings when you want to start a CRRT is timing, which I'll spend very little time on. I believe it is very important that you don't wait too long. As I already mentioned, in our units, it's not easy to start it when the patient needs it. The mode, and Dr. Shakthirajan did spend some time on it, the machine, blood flow, dialysate flow, replacement, ultrafiltration, anticoagulation, and how do you monitor these patients. So I will just go quickly on some of these things. Whenever you are doing monitoring of your patients, you will want to look at sugars. Hypoglycemia is a major problem. Hyponatremia or hypernatremia, hypokalemia, hyperkalemia, all these things can occur, and you may want to do monitoring of these things little early, every 4 hours in the beginning, but as the patient stabilizes, you can switch over to 8th hourly or 12th hourly also. ABG is again the same. Dr. Shakthirajan did mention it takes around 4 hours for acidosis correction on a CRRT circuit, whereas in a intermittent hemodialysis or HDF, your clearances are much higher and you can get a acidosis correction earlier. It also depends on what type of anticoagulation you are using. When you use citrate, citrate has to get in and get converted to bicarbonate. I will not spend time on anticoagulation. My subsequent speaker who has done some original work on anticoagulation in CRRT will talk on it. APTT, of course, we want to make sure the filter life is adequate, so we will look at it. Urea creatinine is something that we look at only once a day. Calcium phosphorus, again, we look at once a day. Anybody who crosses 72 hours on CRRT, the chances of hypocalcemia, hypophosphatemia increase significantly. And earlier years, we didn't have access to IV phosphate. We had tough time using enema proctoclysis into the Ryle's tube and trying to keep the phosphorus high. But presently, we have a much easier life because phosphorus is available. The sieving coefficient, which again Dr. Shakthirajan mentioned, what you look at is corresponding sample of blood urea and the dialysate, effluent bag urea. You see and take a ratio. Many units across the world, if the sieving coefficient starts dropping below 75%, they know that the efficacy of the filter is not good. So they want to change it. So the thing that you will want to look at is, are you using pre-filter or post-filter? Many of us are comfortable combining it because pre-filter will increase your circuit life, post-filter will decrease your circuit life. but in post filter you are actually increasing the clearance. So keeping that in the background, you may want to look at what you want to actually remove during your CRRT. And as was discussed, because convective clearance is predominant here, you are likely to remove not only small molecules which have a very good clearance on your HD and HDF, you will also remove certain middle molecules and large molecules. So because this patient was getting systemic heparin, we did not give any anticoagulation on the circuit, and subsequently he started improving, hemodynamics got better. Over next 48 hours he was weaned off, and then what we found was he had a very low platelet count. Except for that, he was coming off, hemodynamics improved, switched over to HDF, and because we had looked at the multi-system involvement of liver, lung and kidney, we had asked for a ANA, anti-dsDNA. They came strongly positive in this 38-year-old male. And on immunosuppression he improved, and it's already close to 3 years now he comes walking to the. So CRRT patients, many of them, we do see them in OP after many years. I have some patients who come back after 14 years of being on CRRT for 7 days. So there are patients who require different modalities and they will do well on that particular modality. So the current practice of RRT for AKI, the timing, access, modality, dose, anticoagulation and weaning, if you look at, there is not much consensus on many of these things. Timing, we know now you don't have to rush and do anything too early. Access, we have consensus on which site to use and what catheters to use. Modality, it again depends on the patient characteristics. Dose, there is no high dose. At the same time, there is something called as a minimum dose. You can't go below that. Anticoagulation, most of the world is now comfortable and they have published of good outcomes with citrate, whereas weaning, again, there is not much consensus how to go about it. So our goals would be to maintain fluid, electrolytes and acid-base homeostasis, prevent further insult to the kidney. You may see some of our AKI patients who have significant hypotension, or you are not able to wean them off dialysis because every time that you dialyze, there is a arrhythmia. So these are the patients who are likely to do much better. And Dr. Lobo did mention 2 cohorts of patients, liver failure and anybody with a brain injury, who are likely to have significant change in their osmolalities. So they are the patients who should be shifted to CRRT in a ICU. So as far as timing is concerned, there is too early is not good or not necessary. Too late, you can as well sign the death certificate. I will not spend much time here. The decision, as I told you, involves a lot of things, and presently we know that if the time has elapsed, sometimes the benefit keeps coming down. So you should have some modality in your unit wherein if somebody requires it, you have a wherewithal to take a decision as soon as possible. The current practice of RRT, these are the list of 11 indications where you have to start, whereas many times in clinical practice you cannot wait for a life-threatening hyperkalemia or life-threatening acidosis. If you look at the pros and cons, I think we all, even in our day-to-day practice, take the middle path, and that is what we should stick with. This is data from Akin network. We were part of this data. Almost 6,647 patients screened in the ICU, and I wanted to present this because if you look at the developed world and the developing world, there is a little difference in the type of AKI in the ICU. At the same time, your sepsis scores and severity of illness scores are lesser in developing world. But when you look at the initiation of dialysis, we are quite late, and we don't do for acidosis. We are little creatinine centric, and may not be surprised, we are using different modalities including CRRT, but when you look at the outcomes, when you discharge patients from your ICUs, the dialysis dependence is much higher than what the developed world has published. Across the developing world, probably because the initiation is delayed and whatever that we are doing as a prescription looks like we are making our patients more dependent when they leave the hospital and they may not recover as much as. And this is CRRT registry, Southeast Asia RRT registry. We are part of it. These are outcomes that we know in the first 2 years. Non-recovery is a major problem, and if you compare this with the developed world data, there is a significant difference in your AKI recovery in the developing world compared to, and to my understanding, it is because we are creatinine centric when we start our RRT. We don't do it for non-creatinine indications, which I showed you from the Akin network, either for acidosis or for fluid overload. I'll skip the details of the CRRT, but it's a very good study. The principal investigator is Natachai from Bangkok, and many countries including Vietnam, Thailand, India are part of this. So I again want to emphasize, look at your patients as demand versus capacity. You will be able to take a decision regarding initiation in a much better way than allow them to go on to a stage where you may make them dependent or mortality is higher. If you consider this demand versus capacity paradigm, you will have 4 groups where you have high demand but good capacity, high demand, low capacity, normal demand, low capacity, and low demand and low capacity. So in this, obviously, in those who have less capacity, you will want to start earlier, even if they don't have a creatinine which is above 4 or 5. So regarding the timing, most of you are familiar, ELINE trial, Akiki, ideal ICU, and start AKI. And as I mentioned, though there are differences between these groups or the data that has come out of, some of them are surgical patients, some of them are medical ICU patients, the consensus is you don't have to start for everybody who comes into ICU with a very soft indication. But once there is a decrease in urine output, there is acidosis starting, these are the patients that you look at in the paradigm of demand versus capacity and take a decision. So we won't go into the details of these data. And please keep in mind, there are several non-AKI indications for RRT, and they will determine your outcomes and mortality also. So 2 conditions, as I told, raised ICP and severe hemodynamic instability, wherein CRRT scores over the others. Liver failure also because of the hepatic encephalopathy that we talked of. Different modalities, I'll not spend time. You should be familiar with all the circuits and what you should be doing as a prescription depending on what modality you are choosing, and you should be comfortable moving from one type of modality to another type of modality. You may start your patient on CRRT, switch over to HDF once the patient is better after 3 days. Then you may want to discharge if the patient is not improving on a peritoneal dialysis. In several of our patients, we could do that. Sometimes patients are like this. This is a young male, toxic fumes inhalation, came to hospital walking, went on ventilator. You can see that he is on CRRT. Next to the CRRT, there is a sepsis filter. There is a ECMO running on the right hand corner. So when you have complex patients in the ICU and multi-system involvement, when most organs need support, CRRT scores over other modalities to run it in 24 to 48 hours to make sure that the patient comes off one by one all the supports. And unfortunately, many of us have moved away from PD, but acute PD, this is one of our patients post CABG whom we manage only on cycler PD. We should still do it. And in the data of Akin, I showed you, developing world had some proportion of PD, and many of you may know Brazil does a high volume PD with very good outcomes for AKI. So most of us should be aware that whatever you are doing to your patients in the ICU, majority of them get into a spectrum of CKD, and that is the reason you should be worried about your modality and your prescription being very good, so that you don't push your patients. And the data that I showed you, dialysis dependence at discharge and also at 90 days from discharge. One of the things that we now know is each time there is an insult AKI, there is a step ladder pattern of progression from AKI to CKD within 90 days, and we now know that there are disease modifiers. Depending on what you do in the ICU to your patient, you may actually pushing your patients from AKI to CKD spectrum. So among the causes for CKD in a country like India now, AKI contributing to CKD is close to 25 to 30% or so. So we have to learn to treat our AKI in a better way and make sure that we are aware your complications of AKI are not only short term but also long term. This is the pathophysiology of AKI to CKD. I'll skip that and try to go back to our topic of the day, the prescription. So when you look at your patients in the ICU, consider renal replacement as one concept, renal support as the other concept. When you consider it as a broad concept of renal support, you are not going to wait for those very significant reasons like acidemia, very severe, or a hyperkalemia of above 6. You will start RRT a little earlier, and that is what probably determines your outcomes to be much better. One of the reasons that you and I have very bad outcomes in the ICUs is patients are fluid overloaded. This particular cartoon talks of a fluid overload of 5 to 10% increase in the body weight of the patient. You get a significant increase in the intratubular pressure, and we now know from large randomized data that those who are fluid overloaded, the outcomes are bad. They die more often, they have more ventilatory days, more ICU days, and their dependence on dialysis is more. So to my mind, if you are not looking carefully at the cumulative fluid balance in your patients in the ICU, you may not be starting any modality to remove the volume early enough, and new onset AKI also can occur just because of a fluid overload state. Normally the filtration pressure at the glomerulus is around 14. With 5 to 10% increase in your body weight of volume, you will have it dropping to 4 centimeters, and that itself will cause new onset AKI. So if you are giving saline to your patient, it is like 1 liter of saline is like making a ICU patient eat 20 Lay's chips packets. So that is something that we miss often, and we pump fluid into our patients without understanding the volume at each organ is going to cause bad outcomes. The lung, the liver, the heart, the brain, each one of them are actually congested and they have very poor outcomes. So developing world, there was a need to come up with some consensus, and the ADKI came up with what is known as a 5R approach. Many of you may be aware, the first ADKI done in India was in Hyderabad. Risk assessment, recognition, response, renal support, and rehabilitation. I would encourage all of us here, especially the students, go through all these 6 papers which came out of ADKI from Hyderabad: detection and management of AKI in the developing world, AKI risk assessment, prevention and therapy, renal support. The renal support paper talks in detail of how to prescribe RRT, including CRRT, in a developing world, and of course how do you rehabilitate these patients. Then moving from and choosing a modality depending on what is the indication, which modality to choose, and how do you move from one modality to another modality is also discussed in this particular paper. So the other ADKI immediately following this Hyderabad ADKI was something conducted by Ronco, talking of precision CRRT. One of the things Dr. Swarnalata wanted me to just quickly mention was this particular ADKI talked of precision CRRT, moving away from, this was conducted in Asiago, and 4 papers came out of it. One of them was on solute control in CRRT. So what we understand now is each of our units, when you are running a CRRT program, you have to have a default prescription. If your technician calls you 2 a.m. in the morning, this patient needs, they should know a default prescription to be started. Next day morning in the round, you may want to change the prescription to either increase the clearance or decrease the clearance. In fact, patients don't stay rock steady at a particular metabolic milieu. You can start off at a default zone, increase high solute clearance, go back after 3 days to a lesser clearance. So you should be able to have that much of manipulation in your circuits and prescription so that you are able to deliver what the patient requires on that particular day. So prescribed versus delivered dose, you have to be looking at, as I mentioned, sieving coefficient, blood urea and corresponding effluent bag urea is a good way, and we do it every day in our CRRT patients and know that our clearances are good. And most often across the world now we know 15 to 20% you may actually not achieve the prescribed dose. Let me skip that. So monitoring, as I told you, these are the things that you look at, your hemodynamic parameters and fluid status. Please spend some time and make sure your charts have cumulative fluid balance and not the last 24 hours. If your cumulative fluid balance you achieve nearing, if the patient is overloaded when you see them, your aim is to get them off and removing hour on hour extra volume. The best modality is to use a continuous modality. One of the things that you have to know when you prescribe, every 10 liters of effluent volume will add close to 7 ml of GFR. So one of the criticism for high volume CRRTs is outcomes are not good because life-saving antibiotics are being cleared. So when you use a CRRT and you know your effluent volume is so much, you have to add that GFR for your antibiotic dosing also. This becomes one of the cornerstones for ensuring you have good outcomes when you are running a CRRT with good clearances. You have good clearance, patient's fluid improves, metabolic milieu improves, patient will die of sepsis because you are not dosing them adequately with the antibiotics. So I think with that we will go on to weaning. No consensus here, but there is some data which talks of furosemide stress test to decide when to start RRT, furosemide stress test to decide when to stop RRT. You have a doubt, your patient has started making some urine, roughly 300, 400 ml. You do a FST, very good result, you can stop your CRRT and wait. This paper actually talks of using FST as a modality to decide to wean from the RRT. Current practice, most of us see day on day the serum creatinine, and if it is falling, we are comfortable reducing the clearances and giving them some holiday if the set is clotting. Some of us have used urinary urea creatinine. If the urine has started, you look at today's urinary urea creatinine, today's urinary creatinine excretion, next day you repeat it, and the urinary urea and creatinine is going up, you know that your kidney is recovering. But there is no definite consensus on what modality to or what test to use when you want to stop it. Urine output improving, serum creatinine and urea coming down, you are comfortable. So with that, follow-up of AKI extremely important. As I said, many of these people will go on to CKD, and the present understanding, AKI up to 7 days, AKD is when the patient enters after 7 days up to 90 days. From 90 days you call it as a spectrum of CKD. Most of our patients, and my understanding now is 90% of our AKI patients get into AKD and get into CKD, and we determine that depending on when you do, what you do, how you do. So to conclude, in the real world, for you and me, AKI is very common. Patients are very, very different. One patient is very different from the other patient. You have to learn to offer all the modalities that are available today in our armamentarium and choose a modality for a patient depending on what the patient requires. And you should be comfortable as a unit, not only the nephrologist, the intensivist, the nurse, technician, about a default prescription, and then visit the prescription every day or sometimes twice a day to change your prescription so that you deliver what you want for the patient. Thank you very much.
Thank you, sir, for that excellent talk. I had the opportunity to work under Dr. Chakravarthi in the initial days of my nephrology career in Care Hospital, where it's a high-intense cardiac unit, and I think he's one of the interesting persons to start CRRT and senior consultants in Hyderabad. Sir, as you said, early initiation instead of looking at creatinine and then starting CRRT by looking at the clinical parameters like acidosis, sepsis, so it does wonders in the early stages. So, any
So thank you, Dr. Chakravarthi, and it's nice to see Indian name there in the guidelines, and congratulations for that. So my question is, see, now CRRT is available in government sector as well. We also have CRRT and HDF as well. We are doing more of CRRT rather than HDF. But most of the patients admitted in government general hospitals vis-a-vis the developed world are community-acquired AKI patients still, and who are hemodynamically most of the time stable. And we do IHD for them. In your unit, do you do CRRT only for hemodynamically unstable patients? I'm talking only about the renal failure domain, not about the other indications. Or there are other patients who are otherwise fit for IHD, still you prefer and do CRRT for them?
So if somebody can get away with IHD or HDF, we always do only that. Hemodynamically unstable, we do have, and the present unit I'm working, a lot of liver failure work. We get bilirubins of 45, 50 because of the gastro unit that we have. That group of patients, and then of course the intracranial pressure, they are the ones where we start off with CRRT. But very bad hemodynamics, and what we use as a thumb rule is more than 2 inotropes. We offer CRRT. Even there, if the consent is not there, we end up starting HDF, giving them a trial for 24 hours also. So if, just to continue what Lobo has said, even in our unit, in the ICU, if 10 patients are dialyzed, the one of them is on CRRT. Close to 8 or 9 are continuing on HDF, and we have good outcomes. There is one paper from Apollo Chennai, lot of CRRT, they introduced SLED, and they published after 5 years of using SLED. During this period, in the 5 years and the 5 years before the SLED was introduced, they compared the usage of CRRT. It had come down by 65%. So introduction of HDF or SLED into ICU reduces the CRRT numbers in that unit, at least, this is Indian data, by 65% or so. So I am trying to get across saying you will have different set of patients, especially if you are a tertiary unit or a quaternary unit, wherein some patients benefit from a modality. You have to be well versed in that modality to choose. Regarding early initiation, Karthik, I don't think anybody in India does a early initiation, because we can't. Even if you want to, you can't, because as I mentioned, one of the barriers is cost in our patients.
So recently I had a patient a week back, so she's doing very well now. She's out of CRRT.
No, as I told you, many of you may remember a politician who was stabbed multiple times, who had bullet wounds, came to us with no pulse, no BP. I'm sure many of you remember. That politician is still going around making politics. So he was managed on CRRT for 14 days, and the first 48 hours there was no pulse, no blood pressure. And he is fine today, though his creatinine is 1.7. So CRRT in a particular patient does wonders, and I do see patients who come after 10 years doing extremely well.
So the second point is like, what would you suggest? Like, start with a default prescription and up titrate, down titrate for general people in a government sector. You know how the setting is.
Yeah.
Technicians would be initiating it, or students would be initiating it. Different levels of expertise. So what do you follow? Do you upfront give a precision prescription, or you give a default prescription and up titrate or down titrate? And how frequently do you do it? I mean, once in a day is okay. I mean, for the first day, shouldn't it be a little bit more frequent? How do you do it?
So one of the things I've learned in the last 20-25 years is, when you have a CRRT program running, you have to have a default prescription. If you tell your technician start CRRT, they should know what modality, what blood flow, what dialysate flow, what replacement. That should have been started, and maybe 4 hours or 6 hours later, you can always relook at the prescription. The default prescription, everybody who is handling the machine should be aware of. And it should not have too less a clearance, because we are comfortable now having around 30 ml clearance. In the initial days, I'm talking of 2004, 2005, on an average, I used to get 7 phone calls when a CRRT circuit is running in the night. Now I don't get any phone calls because my colleagues take, but having a default prescription and everybody on board for a default prescription helps. Next day morning round, you have to change it based on what the patient requires. and sometimes twice a day you may want to revisit the prescription. Most of the times, first 40 to 72 hours, you have to get very good clearances. I just showed you some data which Shaktirajan also showed. Your prescribed dose versus delivered dose, there is almost 25% difference. And the best of units in the world. So you have to get a higher clearance, effluent dose.
Thank you, sir.
We do. In fact, we transition quite early in liver failure patients from CRRT to HDF. It roughly takes us around 72 hours again. We also have started doing a lot of plasmapheresis for very high bilirubins, like 40, 50, 60. And at least the short-term outcomes are extremely good. And we have to follow, and I had never done this before I moved to the new unit. Our liver team gets patients with that high bilirubins, and we do almost 3 to 5 sessions of plasma, bringing down these bilirubins to 20 or less than 20. And they do very well in the short term, and if they go for some other, it's like a bridge.